Hi, everyone. Welcome back to Clinicians Brief, the podcast, where we have the conversations behind the content. I'm your host, Dr. Alyssa Watson, and today we're going to be talking all about CPR. My guest is Dr. Jake Wolf, a board-certified veterinary criticalist and a clinical assistant professor at the University of Florida. Dr. Wolf recently wrote an article for Clinician's Brief where he summarized the top 7 updates for veterinary cardiopulmonary resuscitation. And he's sitting down with us today to talk about some of these key changes to the 2024 Recover Guidelines and what these changes actually mean for clinicians and veterinary teams who are providing care during these real-life emergencies. So right off the bat, I just want to welcome you, Dr. Wolf. We're so glad that you can be here today. I'm very excited to talk about some of these updates. But before we do that, I'd love to just give you a chance to introduce yourself to the audience and tell us a little bit about your journey.
Yeah, thank you so much for having me. As you said, I'm Jake Wolf. I am a clinical assistant professor here at the University of Florida. I've been here about 4 years. I'm originally from upstate New York and did my undergraduate at George Washington University, where I majored in religion, and then did vet school at Cornell and followed with my internship and residency at the University of Pennsylvania before moving down here. And I think some of my passions here at the University of Florida, I really enjoy mechanical ventilation. I really enjoy envenomation cases. We have a lot of venomous snakes down here. I enjoy CPR, of course, septic patients, but my real passion is teaching. And so getting to teach the students and house officers and technicians has been a big focus of mine.
Yeah, I love that. I love when people can combine their passions. So many, I feel veterinarians are fantastic teachers. It's such a big part of our job, communicating with clients and talking them through what's going on. So let's jump into this because I know our audience is going to be really excited about this topic. I was definitely excited about it when I saw the article. The Recover Guidelines really haven't been updated since 2012. So what do you think kind of drove these changes? And do you think that they were overdue?
Yeah, I think it's hard for me to speak to what drove them initially. I was initially not one of the domain chairs for advanced life support and was brought on kind of at a later stage. I started as an evidence evaluator, evaluating individual questions that were being asked. And I did one of those, and then Dan Fletcher asked me to do a second one. And so I did a second one, and then he said, actually, we're having some trouble getting the advanced life support moving. Can you join and help with that? And so that's how I got into that role, and really opened up a lot of these CPR opportunities for me. And I think in talking to them, their goal was to update after 10 years. And then as things often happen, things get delayed. We got busy, COVID hit, and I'm sure delayed a lot of these these changes. So yeah, there were a lot of big changes, and I think ones that we thought would be coming, especially with some of the drug doses. And so I think they were overdue, and it's kind of changed our approach in the future. We've had discussions, should this be done on sort of a rolling basis rather than these periodic every 5 to 10 year updates and guidelines. And I think with the amount of literature that comes out about CPR, especially as more and more people in veterinary medicine get comfortable doing it, we're going to see more and more literature come out. These updates may need to happen more frequently.
Yeah, and it really got me thinking too about just individual practices. As a practice, are we waiting until we get these really big, guideline reviews, or should practices be revisiting their own individual CPR protocols more frequently? Like, say, if they have staff changes or things like that. What do you think should prompt kind of a team-wide refresher?
Yeah, I think regularly scheduling them is really important. So here, what we do is all of our emergency and critical care doctors and technicians, we pay for Recover basic and advanced life support training every 2 years. So they go through that online module system every 2 years, and then all of the technicians go through yearly in-person training refreshers. And those are required by the hospital for us to stay up to date. So I think at least yearly updates are needed. And I think that's in a hospital where we're doing CPR pretty frequently. And so we're getting to practice CPR pretty frequently, sometimes once or twice a day. And so, again, you don't lose those skills. If you're doing them less frequently, you might need to have more frequent refreshers because you're not utilizing those skills on a regular basis. So 2-3 times a year might be needed for those sorts of practice sessions. I think the other component that really can never be ignored is when you do CPR, after making sure you're taking that time to debrief as a group and discuss, what went well for this session, and do we want to make sure that we continue to do in our subsequent ones, but also, we actually didn't follow the most recent guidelines. I forgot. We did maybe the older ones, or we forgot this step, and we need to make sure that we're incorporating that. And so I think learning in the moment is so important in solidifying that in our memory, that those in the moment refreshers are probably even more important.
Right. That's a really good point too, to remember to take that time after everybody's adrenaline has come down a little bit and revisit, for the whole team to kind of air how they felt everything went. We're going to walk through these, kind of 7 updates that you outlined in the article, and I'm just going to go through them in the order that you presented them. The first one starts with compression depth. Okay, so there's this in the guidelines now. We're differentiating our compression depth when we're performing chest compressions on whether or not the patient is in lateral recumbency or dorsal recumbency. Can you kind of explain why that matters for outcomes, or if, are there specific breeds this is more relevant for? How should teams be applying this really in practice?
Yeah, I think as a refresher, very few of our patients are going to be compressed in dorsal recumbency. I always say the ones that are in dorsal recumbency are kind of the most humanoid. We're brachycephalic, so the brachycephalic ones are kind of shaped like us. So French bulldogs potentially, and most English bulldogs are going to be the ones that are done in dorsal recumbency. Everyone else, small dogs, medium, large breed dogs, they're going to be in lateral recumbency. And so it's really a small segment. And in discussions, I think most of us recommend even starting the bulldogs in lateral recumbency until you're able to intubate them. I don't know if you've ever intubated a bulldog in dorsal recumbency, but that giant tongue and all of those, like that pharynx, just hang down and over the glottis and make it really difficult to visualize. So we recommend still starting them in lateral and then moving them to dorsal as soon as intubation has occurred. And the reason is, like, if you've compressed a patient in dorsal versus lateral recumbency, you can tell the compliance of the chest is very different. So the compliance is much lower with those sternal ones, and I think there's a much higher degree of higher risk for causing damage with trying to get a greater compression depth. And then and so the guidelines for the patients in dorsal recumbency are largely based on the ones found in human medicine, who are being compressed similarly, where you're compressing for a quarter to a fifth, whereas the patients in lateral are going to be more like a third to a half. And I think this is really where you rely on your teammates. CPR is such a team sport to give you individual feedback during your compressions. I think when you're doing compressions, it's really challenging to see how much you're compressing that patient. And so the people who are not doing compressions, who are surrounding, you're requiring that closed loop communication where they might need to say, hey, it looks like you're actually compressing too far, and we might cause some iatrogenic damage, pulmonary contusions, things like that to this patient. Let's decrease the depth. Or actually, it looks like you're minimally compressing this chest. You need to compress a little bit harder. And so I think that's the main way that we can implement that. It's going to rely on the teammates surrounding that to give that feedback and feel comfortable giving that feedback to those compressors.
Yeah. You talked specifically about some of these brachycephalic breeds, French bulldogs and things like that. That kind of leads into my next question, where ventilation recommendations have also been updated, and they've talked more about really utilizing kind of a tight-fitting face mask, and that being preferred over something like just mouth to snout breaths when you haven't been able to intubate yet. But for something like a brachycephalic, like a French bulldog or something like that, how are we constructing those tight fitting masks? Are there modifications that need to be made in order to help that?
Yeah, I think, excuse me, I think the priority for all of our patients should still be, all of our dogs and cats should still be intubation. That should always be the gold standard and what we're aiming for. And so then these are talking about if we are unable to intubate for whatever reason, what should be the next step. And I think the reason that we prioritize a tight fitting mask is you're going to get a much better seal around the nose and mouth to be able to actually deliver those breaths. And so to be able to actually ventilate that patient. Mouth to snout, our seal is going to be much looser. There's risks associated with it as well, occasionally. And so again, we're going to prioritize that tight fitting mask. My preference is usually to use one of the plastic masks with the rubber seals around it, and use that as your tight fitting mask and choosing the size. And I think even in most brachycephalics, that's going to be adequate, or will be able to provide a mostly adequate seal. You may need to hold the patient's mouth closed, depending on the size of their mouth, to make sure that the mask fits over it completely. But I think that should be sufficient for most patients. If not, you could modify it using maybe like some either elasticon or white tape to try to make the lumen a little bit smaller if you don't have one that's actually sufficient size. But that's going to take time, and so doing that quickly for these patients who need these interventions sooner rather than later would be important.
And then you alluded just a little bit to, not only is this better, oxygen delivery to the patient, but also we are addressing some safety concerns for rescuers. What might those be?
Yeah, I think the main ones that we think about are infectious diseases. So ones that go through, leptospirosis potentially for a patient, probably not from those secretions. And then we've had ones occasionally with neonates who people immediately do mouth to snout, and we don't know the reason for potential abortion. Again, leptospirosis or brucella or something like that could be on the list, and those carry risks for human rescuers as well. And so in those patients, if there is a possible risk of either infectious disease, or if the patient could have overdosed, if they could have ingested or like aspirated a large, inhaled, there we go, opioids, those carry too great of a risk to the human rescuer. And if intubation is not possible in those patients, if a tight fitting mask is not an option, we would not recommend mouth to snout due to the risk to the rescuer. And in those patients, we would recommend compression only CPR and no ventilation. I think that I've never been in a situation where that's been possible. The vast majority of my patients I'm able to intubate, thankfully. But something to keep in the back of our mind, that it's never worth the health of your teammate, your team members in those situations.
Exactly. We got to prioritize the health of our team members, because we can't help anybody if we're not healthy ourselves.
Absolutely.
So, next on the list is end-tidal CO2 monitoring. This was emphasized much more strongly in the new guidelines. So can you talk to us a little bit about the role capnography plays in not only confirming whether you've intubated correctly, but also assessing that compression quality like we were talking about a little earlier?
Yeah, I think one of the challenges, when we're in a high stress situation and we're intubating a patient who's not in a normal position. We're used to intubating them nicely in sternal recumbency, where we don't have a ton of stress and we have a little more time. And then this is very different. The patient's in lateral. Maybe there's a bunch of secretions. Maybe they regurgitated. Our visual, our vision's usually impacted. It can be really challenging to intubate them and to be confident that you intubated them and didn't put the endotracheal tube in the esophagus. And so I think this is really where the role for the end tidal CO2 comes in at the outset and getting that attached soon. And so we know based on different studies that an end tidal of greater than 12, if you're getting values greater than 12, indicates that you are in the trachea. And so if you're getting those values greater than 12, you can be pretty confident that you're not, that you're in the trachea and properly intubated. If you're getting values less than 12, you could be in the trachea, or you could be in the esophagus. And so then it's time to troubleshoot. And so your steps for troubleshooting might be grabbing your laryngoscope and checking placement, making sure you're in the right location. Or if you intubated, maybe having another rescuer take a look and make sure they agree, since you were the one who visualized it initially. Making sure your cuff is inflated, and make sure that's not the reason that you could be getting those lower end tidal CO2 values. And then really your last differential, if you're definitely in the trachea and your cuff is inflated, the main one is my cardiac output insufficient? And so your reasons for that would be your compressions are not strong enough. And so then we're running through all of those sorts of things to try to determine, are our compressions appropriate? Are they compressing a quarter to a third if the patient's in lateral recumbency? Are their shoulders are their shoulders directly above the compression point? Are they compressing the proper location for the patient based on their anatomy? Are their elbows locked? All of those sorts of things we should be assessing again as a team and giving feedback to the compressors. And then in some patients, we might be doing all of those things, but still we're not getting adequate compressions, or we're not getting adequate cardiac output, and maybe that patient is not going to achieve return of spontaneous circulation. And that's kind of the last thing that we can use end tidal for. If we see a big spike in end tidal up to 25, 30 or higher, that's usually our earliest signal that we've probably achieved ROSC in those patients.
Okay. The guidelines did cite end tidal CO2 of above 18 as kind of your target during compressions. And sounds like you just ran through all of our, really good adjustments that we can make. So, and again, stressing that, your team is there to give you feedback as you're making those compressions on where you want to be and having your elbows locked and all those things.
Exactly. And just
go ahead. Sorry.
Just to go on that a bit, I think one of the things that we discussed, we discussed three different positions, or it was discussed three different positions for small dogs and cats for compressions. And we don't know which of those is best. And some of it might be based on compressor preference. I know, like if I'm doing the single-handed compression, my hand tends to fatigue very quickly. And so that's not my favorite one to do. But the other thing that we can base that on is based on the end tidal. And so you can try out those different techniques on that patient. And if we're seeing a much higher end tidal using one of those techniques, that's probably the best technique for that patient. And so using that to modify your approach is another benefit of being able to use end tidal.
That's great advice. What about those practices? We still do see some practices that don't have capnography available. How are those practices still able to kind of optimize their CPR efforts?
I think it's going to be really challenging because there's limited diagnostic tools that are going to be beneficial in CPR. We have ECG, we have capnography, we have blood gas, and maybe point of care ultrasound, but none of those other ones other than capnography are going to give us really great information about compression quality, unfortunately. I think it's that closed loop communication and providing that feedback about compression quality and compression posture that if you don't have an end tidal, that's really the only thing that you can do in practice. I think the other option, there are different compression monitoring devices that are mostly used for research and for practice, but they measure the quality of your compression. They measure the depth of your compression, the recoil from compression, and your rate of compression and how adequate those are. And so if you don't have an end tidal, I guess the other option would be to purchase one of those devices and then use that to practice with your teammates and say, okay, you delivered quality compressions for 90% of the time, 90% of your quality compressions were adequate depth, like great job. That's considered adequate in human studies if we use that on a mannequin. And so presumably you're going to be able to do that in these patients and deliver high cardiac output. Whereas if you have a rescuer who, you use that device and they're delivering 30% quality compressions, then maybe you have a discussion with that person about how we can better modify how they're doing compressions and then retest them and see if they improve after those modifications.
Doesn't sound though like there's anything that's going to give you kind of a replacement for that real-time information that you get from capnography in the moment.
Unfortunately not.
Every cat's visit to your clinic is an opportunity to spot the subtle signs of osteoarthritis pain. When you diagnose OA pain, be confident in recommending Silencia for nivetmab injection. Monthly Silencia controls the pain of OA in cats, helping to improve their mobility, comfort, and well-being. Turn one-time visits into lasting partnerships. Visit SilenciaVetTeam.com to learn more. For use in cats only. Women who are pregnant, trying to conceive, or breastfeeding should take extreme care to avoid self-injection. Hypersensitivity reactions, including anaphylaxis, could potentially occur with self-injection. Silencia should not be used in breeding, pregnant, or lactating cats. See full prescribing information at SilenciaPI.com.
So let's jump to something a little bit different. We're going to talk about shockable and non-shockable rhythms. And I will admit I could really use a refresher on the difference between these shockable and non-shockable rhythms. And maybe could you share a few examples of each that we might see?
Yeah, absolutely. So our shockable rhythms are by name going to be the ones that are going to benefit from defibrillation, from a shock. In CPR. And so we have two shockable rhythms, ventricular fibrillation, which is by far the one that we see more commonly, and then pulseless ventricular tachycardia. So those are patients, we usually see kind of the R on T pattern on ECG, no pulses palpated, and those patients have a rate of greater than 180. Whereas the non-shockable are rhythms that are not going to benefit from defibrillation. And so we have two of those as well, asystole, the classic flatline, and then pulseless electrical activity. And pulseless electrical activity can look like any rhythm that's less than a heart rate of 180. It just does not have a corresponding pulse associated with it. And so that one can be kind of the trickiest one. They can be ventricular rhythms. They can look like sinus rhythms. They can look like almost anything other than those other three rhythms.
Okay. Well, let's talk a little bit about those non-shockable rhythms first. So one of the things that was updated, actually both protocols for atropine and epinephrine were changed, in these updates. Atropine is now recommended only as a single dose. So what was the impetus for the shift away from repeated atropine doses during CPR?
Yeah. So there's very little evidence that atropine is beneficial in CPR to begin with. And in human medicine, it's been dropped off the guidelines, I believe. And so we weren't necessarily comfortable doing that. We think that dogs and cats suffer respiratory arrest and therefore maybe have more vagal activity in their arrests than people do. A lot of people suffer cardiac arrest rather than respiratory. And so I think that has been, and so we weren't comfortable dropping it off. But I think the question is, could this do harm? And there are some experimental studies that looked at high doses of atropine, and those high doses of atropine used during CPR did lead to adverse outcomes, decreased return of spontaneous circulation, decreased survival. And so the half-life of atropine is pretty long. It's not short-acting like epinephrine. And so what we kind of talked about is, well, if you're administering many doses every other cycle, every 4 minutes, atropine, that's essentially, and it has a long half-life, that's essentially administering a high dose. And so could those high doses potentially lead to adverse outcomes? Because we are not sure that there's a clear benefit, that's why that recommendation was changed to just, if you're going to give it, give just a single dose and then be done from there.
Now, the epinephrine protocol, as you said, shorter acting. So we still, I think we're still recommending multiple doses of that if needed, but they, in these guidelines, moved to kind of exclusively this standard dose epinephrine, as opposed to, there used to be this standard dose and then this high dose epi. I know I have charts in some of my clinics that still have the different
Mm-hmm.
low dose, high dose of epinephrine, right next to that atropine dose. Yep. So what led to that change?
Yeah, I think it was, again, numerous studies in people and some experimental studies in dogs and other species have shown that while high dose epinephrine may lead to more like an increased likelihood of return of spontaneous circulation, there's no difference in survival and no difference in neurological outcome between patients who receive high dose and low dose. And the reason for that is you might achieve ROSC in those patients, but because the high dose is so arrhythmogenic, many of those patients go on to re-arrest from those arrhythmias. And so because there was no difference in numerous studies, and to make things a little bit simpler, where we're not discussing two different doses or when to change from one dose to the other, changing to that just standard dose epinephrine every other cycle. So we said kind of every 3 to 5 minutes, which is not a change from previous recommendations, is what the new guidelines state.
So it sounds like you're giving me permission to grab my Sharpie and just X out that whole column on my chart on the wall.
At least for now. I can't tell you, 5 to 10 years from now, if new studies come out, we might be going, actually, erase that high dose and put it back on.
All right. So maybe I should use a dry erase marker instead.
Yeah, dry erase or maybe a piece of tape or
something. Okay. All right, well, let's talk about shockable rhythms then. For shockable rhythms, so you recommend a biphasic defibrillator, and now we want to start a little lower at 2 joules per kilogram for the first attempt when we're shocking, and then doubling that to 4 joules per kilogram for subsequent attempts. How is this different from what we were doing before, and why did we change?
Yeah, I think the previous recommendation just kind of provided a range. I think it was 2 to 10 joules per kg. And so really not clear, where we should be. That's a pretty wide range.
That's big.
as your facial expressions showed. So not kind of clear where we should be starting on there. Do you start at 10 and then just go? And so I think these recommendations came from a number of studies, and again, people in experimental studies, that lower dose giving us a chance of a lower dose is less likely to induce myocardial injury. And so can we get away with just a low dose defibrillating that patient, hopefully not damaging those myocytes, and getting that patient out of a shockable rhythm? And then if there is an improvement, doubling that dose to 4 joules per kg, and then staying at that dose. And that's mostly because most studies looking at this didn't go at much higher doses than that, and higher doses are going to be associated with increased injury. Again, we're trying to extrapolate these because most dosing in people is just based on a set number of joules, and so people all weigh the same amount apparently, and so we're just kind of saying, we're trying our best and saying that's essentially a 2 joule per kg dose. That's essentially a 4 joule per kg dose for a standard size human. But that's kind of why it was made, trying to avoid giving a little bit more guidance and trying to avoid higher doses that might be associated with myotoxicity.
Yeah, it's absolutely difficult when you go to look up a dose and there's just a huge range that's
Right.
double or triple, and not knowing, at least where to start
Exactly.
can be very frustrating. So I'm certain.
Especially with,
Yeah.
yeah.
Especially with a defibrillator.
Right. And we don't do that very often,
Mm-hmm.
like defibrillation is probably not something that most of us do very commonly, and so aren't very comfortable with just that dose off the top of our head. I think there was a study that showed that only like 4% of initial rhythms are shockable, and so that's not something that even people who are doing CPR frequently are encountering very often. So, and that's why I think that guidance is needed.
The last kind of big update that you talked about in the article was this use of esmolol. So if we have refractory shockable rhythms, so you're not able to, get them to convert, you can maybe try esmolol. What's the proposed mechanism of that? And when do you think that, clinicians might realistically reach for this in practice?
Yeah. So we kind of talked about 3 treatment options for refractory shockable rhythms. And we defined refractory shockable rhythms as, one, the literature is not consistent in what qualifies as a refractory shockable rhythm. So we just kind of had to pick something. And so based on what many have done. And so we defined refractory shockable rhythms as you've administered 2 shocks. So you've defibrillated the patient twice, and then you begin CPR. Again, you begin compressions again. That patient is defined as a refractory shockable rhythm. So after you delivered that first 4 joule per kg dose of defibrillation. And in that point, you can consider 3 different treatment options: vasopressin, or if you don't have vasopressin, epinephrine, lidocaine for dogs, or amiodarone for cats, and esmolol. And we don't know whether you should just choose one of these, choose 2 of them, choose 3, administer all at once and see what happens. We don't know. And hopefully future research will help extrapolate that. But I think there was an interesting study that used the RECOVER database out of Washington State from a couple years ago that published on shockable rhythms. And like I said, they found very few patients presented with initial shockable rhythms, but they did find that a decent number of patients developed shockable rhythms during the course of CPR. And so that asks us that should make us ask, why did they develop shockable rhythms? And what they found was that patients who received epinephrine had something like a 11 or 12 times chance of developing a shockable rhythm during CPR. And so could administration of epinephrine by stimulating those beta-1 receptors in the heart make these patients go from something like asystole or pulseless electrical activity to ventricular fibrillation? And if so, could a beta blocker be the beneficial treatment for these patients, a beta blocker like esmolol? And so for me, how do I use this in practice? If I have a patient who develops a refractory shockable rhythm during CPR, I'm much more likely to give esmolol to those patients than if they initially present. Maybe I'm going to use lidocaine for that patient or something like that. And so that's my general approach, and that's the reasoning why we became open to adding that. Again, these were kind of as suggestions. We don't have a ton of evidence for any of those three options for refractory shockable rhythms, and we don't see them very commonly in veterinary medicine, which makes it hard to create those clinical guidelines. But that's kind of the thought process and the pathophysiology behind it.
Yeah, definitely still good to know kind of the rationale behind why you would want to use it or why it should work. And that can give you a little bit of confidence on when to reach for it. Absolutely. A couple kind of wrap up questions. CPR, is definitely something that, we practice for, like you said, and we want to be ready for, but when it happens, especially, in general practice where, like you said, we're not seeing these arrests all the time, it can be pretty chaotic. So do you have advice for teams on implementing these new guidelines? Like how are we doing this in the moment? Or is that, like you said, something that we're going to be waiting and kind of rounding on afterwards?
Yeah, no, I think it's even for those of us who do it all the time, it's really chaotic, right? And it pulls every single one of your team members off the floor. They're all focused on this one patient. And so, like you said, it's naturally chaotic. I think not in the moment, but the regular practice is going to be really important. But then I think what's so important in the moment is closed loop communication. So making sure that, if someone orders epinephrine, you have the person saying, pulling up epinephrine, administering epinephrine administered to this patient, and then setting a timer. I think using a metronome or the Recover app or something like that to provide the rate and to remind you when you should be rotating who's doing compressions is really, really important. That app is free. It's really easy to use. I think it helps keep time really well. It lets you know when to breathe, and when to compress. And I think as anyone who's done CPR, you get this adrenaline rush and you want to compress as fast as possible. And you want to breathe as fast as possible. And neither of those things are what we should be doing. And so it helps keep you on task and set you in a little bit more of a calm state. And then I think it's really important to define roles. So identifying who's going to be the leader of CPR, who's going to start with compressions, who's going to drop drugs, and that leader being willing to say, this is what we're doing, and then people giving feedback and saying, oh, actually, that looks like asystole, maybe we shouldn't defibrillate, or oh, that looks like VFib, maybe, and making sure that the team feels comfortable in those moments. But I think those defined roles really help people feel comfortable in what they're doing.
Absolutely. I think so. Out of all of those changes that we've talked about today, which do you think that you would prioritize first? Like if practices were going to adopt, just a few of these, which was the most important? What do you think will have the biggest impact on outcomes for some of these teams?
Well, I think I'm biased in that I like the advanced life support portion because that was the part that I was a part of. But the most important part of CPR, what saves patients, what leads to ROSC, is basic life support. So good basic life support is so, so important. And so I think getting your techniques down for where you're compressing, how you're compressing, that's what's going to save patients' lives. And so making sure your team is trained to do that, is comfortable for, based on which breed, where they should be compressing, based on the size of the animal, where they should be compressing. The position for those is essential. And then if they don't have an end title, that's so, so important for so many monitoring techniques. I think that's the next most important thing. So while I love the drug changes and the defibrillation changes and that sort of thing, what's going to lead to larger improved results is excellent basic life support.
Basic life support and excellent communication between your team members, it sounds like.
Yeah, absolutely.
So, yeah. Well, that was all. Thank you so much for walking through all of that with us. I do have one more thing, though, before we let you go. At the end of our episodes, we actually play a little game with our guests, if you're up for it. It is just a series. Yeah, it's just a series of would you rather questions. They're just for fun. Okay.
Let's go.
Would you rather learn a new skill every year, or would you rather hone one skill and become the best in the world at that one thing?
I think I'm a little bit of a generalist. I'm a criticalist. We have to know a lot of different things. So I think I'd rather learn a new skill every year.
Jack of all trades, something new every year. Okay. Would you rather have to work a relief shift at a busy ER during a full moon or on a major holiday?
Full moon, definitely.
Okay, not superstitious at all? You're all right there?
My nurses often yell at me for saying like, "Oh, it's so quiet in here."
Don't say the Q word.
I know. But okay. Yeah, because I'm not superstitious about it.
Would you rather see only canine medical emergencies or only feline medical emergencies for an entire month?
Oh God, I love them both. I wonder, what do most people pick for this? I have my answer.
You do?
I'm going to say cats because they're so quiet. And I kind of would like a month of just quiet in the ICU.
Just quiet.
Just peace.
Yep. Other than those like hyperthyroid cats that are just like howling.
Exactly.
But by the time they're sick enough probably to see you, they're probably not doing that anymore.
See, now I'm tempting fate, and I'm probably going to, on my full moon shift, only get
hyperthyroid cats
that are yowling the entire hyperthyroid cats and like cats that ate Ritalin or something.
Okay, 2 more questions. Would you rather practice without injectable anxiolytics or without injectable steroids?
I think I'd have to pick injectable anxiolytics.
Yeah, you got to have yours. I figured a criticalist would need his steroids.
Yeah, it just seems so unfair to all my like IMHAs and ITPs that I wouldn't be able to give them IV meds and Addisonians.
Okay, last question, and I feel very fitting, honestly, given today's discussion. If a centaur walked in and needed CPR, fell over, needed CPR, would you start the chest compressions over the man's thorax or over the horse's thorax?
Interesting. I think I would start them over the man's thorax, but
you would.
I don't know.
I think I'd go over the horse's thorax. I mean,
over the horses,
because I figured that heart's doing more of the work.
Do they have 2 hearts?
Well, I mean, I would assume a centaur has 2 hearts, one in the horse and one in the man, but
I didn't know. Okay. Should you compress both?
Could you need a bigger
like 2
team.
Compressors? Yeah. An added complication of them having to time it together, but
right.
I think if they have 2 hearts, I think you have to.
I think we'd have to go with both, and we would have to. Yep, we would have to synchronize our compressions.
Yep.
Okay, I'm going to be expecting these in the next guidelines. I'm going to be expecting this addendum.
I think that's fair. Yeah, mythological creature compressions.
Well, that was everything. That wasn't too bad, right?
Not at all.
Well, I just want to say thank you one more time. And I also want to say thank you to our listeners. We're glad that you were able to join us today. Be sure to check out Dr. Wolf's article at cliniciansbrief.com. And we'll see you next time on Clinicians Brief the podcast.
Thank you so much for having me.
Thank you for listening to Clinicians Brief the podcast. If you enjoyed today's episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcasts on our website at cliniciansbrief.com/podcasts. Or drop us a line at podcasts@instinct.vet. Clinicians Brief the podcast is an Instinct Science production, produced by Alexis Ussery and hosted by Alyssa Watson.